This episode of the Nurse Practitioner Podcast is sponsored by Dakins. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakins Wound Cleanser. Just how powerful is it? Dakins Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakins. In this episode of the Nurse Practitioner Podcast, Mohamed El Hussein discusses dyslipidemia. What is atherosclerotic cardiovascular disease?
Thank you for the question. That will set actually the stage for the listeners to understand why this is so important, why talking about dyslipidemia and lipid-lowering medications is very important in this context. Atherosclerotic cardiovascular disease, or what we often refer to as ASCVD, basically refers to all the clinical condition of atherosclerotic origin, including acute coronary syndrome, myocardial infarction, stable or unstable angina, coronary artery disease. It should be documented using angiography, coronary or other arterial revascularization, such as coronary artery bypass, femoral popliteal bypass graft surgery, history of stroke, transient ischemic attack, documented carotid artery disease, peripheral arterial disease, and abdominal aortic aneurysm. All of these come under the umbrella of atherosclerotic cardiovascular disease, or what we will refer to in our discussion today as ASCVD. Very good question.
All right, excellent. Thank you for that introduction and explanation. What are the statin indicated conditions?
Wow, that's a very important question. However, before I jump into medications, I'd really like to emphasize to the listeners the health behavior interventions before we consider medications in the setting of primary prevention. When I say primary prevention, I'm referring to all the efforts aimed at either populations or individuals to prevent or delay the onset of ASCVD, because I want the listeners to discern that or to differentiate that from secondary prevention, which refers to the efforts to treat known clinically significant ASCVD and to prevent or delay the onset of disease manifestations. So in the context of this discussion today, our focus is primary prevention. As such, and before we go to statins, which are medications, I'd really like to emphasize the importance of health behavior intervention. For example, combining low-risk health behaviors that include achieving and maintaining a healthy body weight, consuming a healthy diet, engaging in regular physical activity, stop smoking if you smoke, limiting alcohol consumption to no more than moderate, and ensuring sufficient duration of sleep are all associated with benefit for primary prevention of cardiovascular disease. If you want more direction on what kind of diet, since we're talking about food here, should the patient consider to decrease that risk, we continue to recommend Mediterranean dietary pattern. The DASH diet, or the dietary approaches to stop hypertension, has also proven to be effective in reducing the incidence of coronary artery disease. Low glycemic index, low glycemic, low dietary pattern, plant-based dietary pattern, as well as dietary patterns high in nuts and legume and olive oil, fruits and vegetables, high in total fiber and whole grains. All of these diets in big studies have shown to be associated with decrease the incidence of ASCVD. It's also recommended that before we jump into medications, that patients with dyslipidemia should engage with at least 150 minutes of moderate to vigorous aerobic activity per week. It might be also beneficial to add muscle and bone strengthening activities at least 2 days per week. Regular exercise has beneficial effects on diabetes risk, hypertension, increased triglyceride levels, and it also improves the levels of high density lipoprotein cholesterol. Now, I have re-emphasized the significance of health behavior interventions. I can go back to your questions related to the statin indicated conditions. Like I said, it's a very good question, but changing lifestyle can also, with the statins, can help. If the patient does not respond to changing lifestyles, then we can consider statins in the following situations. So the statin indicating conditions, by definition, refers to any condition for which pharmacotherapy with a statin is indicated and consists of all documented ASCVD conditions that I mentioned them in response to your first question, as well as other high primary risk prevention conditions in the absence of ASCVD. What I'm trying to say is, if the patient has high risk conditions, even though they don't have ASCVD, we start them on statins, such as, I'll give you an example. Most patients with diabetes, patients with chronic kidney disease, patients with the LDL cholesterol more than 5 millimole per liter, or patient with familial hypercholesterolemia, regardless of their, even if we have absence of ASCVD and they have these high risk conditions, we start them on statins. Thank you.
Thank you for that explanation. Who should you screen for dyslipidemia in adults at risk?
Okay, another an excellent question. The recommendations continue to recommend lipid and lipid lipoprotein screening in either fasting or non-fasting for men and women older than 40 years of age, and at any age if the patient has one of the following conditions. So we start at 40 for everybody. However, if they have one of the following conditions, they have to be screened. One, clinical evidence of atherosclerosis. Two, abdominal aortic aneurysm. Three, if they're diabetic. Four, if they have high blood pressure. Five, if they are smoking. Six, if they have stigmata of dyslipidemia, for example, corneal arcus, xantholasma, xanthomas. These are stigmata of dyslipidemia. Next, I think this is number six, family history of premature cardiovascular disease. Number seven, family history of dyslipidemia. Number eight, if they have chronic kidney disease defined by a GFR of less than or equal to 60 ml, or if their albumin to creatinine ratio is more than 3, and of course that's over 3 months. If they're obese, and by obese I mean their body mass index is more than 30 or equal to 30. Next, I think this would be factor probably number 9. If they have inflammatory disease such as rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, all of these conditions increases the risk of ASCVD, and as such, these patients need to be screened. If they have a history of erectile dysfunction, if they have a history of COPD, if they have a history of hypertensive disorder during pregnancy. So all of these patients should be screened regardless of their age. But usually we start at the age of 40. What I'd also like to add that the non-fasting state is recommended. So I said earlier, fasting or non-fasting. However, the non-fasting state is recommended for everybody except for individuals where the triglycerides is more than 4.5. So if somebody has triglyceride less than 4.5, they can go for their blood test without fasting. However, if the triglyceride is more than 4.5, they must fast at least 12 hours before they undergo the dyslipidemia screening. And that's because if the triglyceride is more than 4.5, it leads to minimal changes in relevant lipid levels and has no effect on apolipoprotein levels compared with the fasting stage. That's why we recommend the non-fasting if the triglyceride is less than 4.5. But if it goes above 4.5, no, they have to be fasting.
We appreciate you sharing those recommendations. How should you screen for dyslipidemia in adults at risk?
The test that we usually order after doing a complete thorough physical exam, we do total cholesterol. We order LDL cholesterol, HDL cholesterol, non-HDL cholesterol, triglycerides. We also order fasting plasma glucose, hemoglobin A1C. And what's new now and is very important is the new test, which is known as lipoprotein little a. Lipoprotein little a. We'll talk more about it. We also recommend that the practitioner order ApoB, urine albumin to creatinine ratio, just to make sure that the patient does not have a chronic disease. So you might ask, like, why the focus is very much on LDL cholesterol. Most of the guidelines have used LDL cholesterol as the primary laboratory measurement for considering initiation of statin treatment and as a treatment target in low, intermediate, and high risk individuals. However, it has been recommended with the guidelines published in 2012, it has been recommended that non-HDL cholesterol, ApoB, could also be used as alternate targets to LDL cholesterol if individuals have triglycerides more than 1.5. So basically, if we have a patient with triglycerides that's above 1.5, it's recommended that we don't only look at the LDL cholesterol, but rather we look at the non-HDL cholesterol and ApoB. And the reason for that is the following. The rationale for this is that above this triglyceride level that is above 1.5, some cholesterol in the LDL particles is actually replaced by triglycerides, which promote the production of more atherogenic, small, dense LDL particles and make the amount of cholesterol in the LDL cholesterol an unreliable reflection of the LDL particle number. In addition, other particles, such as the remnants of chylomicron and very low density lipoprotein cholesterol, as well as lipoprotein little a, all accumulate in the artery and contribute to atherogenesis, whereas high density lipoprotein cholesterol does not. Therefore, the estimation of the concentration of all atherogenic particles requires a broader focus than the measurement of LDL cholesterol. And as such, non-HDL cholesterol indirectly and ApoB directly provides a more accurate assessment of the total concentration of atherogenic particles than an LDL cholesterol. As such, non-LDL cholesterol and ApoB for this reason are better predictors of cardiovascular disease or event risk and benefit of lipid lowering therapy compared to LDL cholesterol. You also might be wondering about what is this LPL, lipoprotein little a. This is the new test. Actually, this is a new test. I'm not sure if it's available everywhere, but I know it's available in Canada now. I'd like just to add a couple of points about lipoprotein little a. LP little a or lipoprotein little a, it's an LDL-like particle, but in which ApoB is covalently bound to the plasma-like molecule called apolipoprotein. The plasma concentration of lipoprotein little a are not influenced by age, sex, fasting, state, inflammation, or lifestyle factors, but are largely controlled by a single gene, usually the LPA on chromosome number 6, and are highly, when I say highly, more than 90% heritable. Individual values are generally stable throughout life. As such, repeat measures are not required for risk assessment. Studies have shown that the risk of ASCVD increases with increasing LP little a levels more than 30 milligram per deciliter in a dose-dependent fashion. Although further evidence that directly lowering the LP little a level reduces ASCVD is still pending. However, finding of studies that showed that high LP little a should alert primary care practitioners to be more active in pursuing the overall ASCVD event risk assessment, which should include careful discussion of current health behaviors, consideration of age-appropriate vascular imaging studies for detecting early evidence of subclinical atherosclerosis in select individuals. And I'm talking here about the coronary artery calcium scores. An earlier introduction of statins or lipid-lowering therapy, especially in intermediate risk individuals or low risk individuals with moderate elevation of LDL cholesterol or a LDL cholesterol between 3.5 to 5.
Can you provide an overview of the management of dyslipidemia in primary prevention?
Studies consistently show that a 20 to 22% relative reduction, there is a 20 to 22% relative reduction for each 1 millimole per liter reduction in LDL cholesterol. Sorry, the absolute risk reduction is dependent on the baseline risk and the baseline LDL cholesterol. Because statin treatment will provide a greater absolute LDL lowering in those with higher baseline values. Therefore, it's recommended that statin therapy be started for all high-risk patients. That is, if their ASCVD is more than or equal to 20%, or patients with intermediate risk, that is their ASCVD between 10 to 19.9, when their LDL cholesterol is more than or equal to 3.5, or their ApoB is more than or equal to 1.05 grams per liter, or when their non-HDL cholesterol is more than or equal to 4.2. So even though they are intermediate risk, but if they have these three conditions, we need to start them on statin therapy. In addition, among intermediate risk individuals with several additional risk factors, such as men 50 years of age or older, or women 60 years of age or older, with one additional risk factors, including low HDL cholesterol, impaired fasting plasma glucose, increased waist circumference, cigarette smoking, hypertension, the evidence remains in favor of statin to reduce the risk of cardiovascular events. The presence of other modifiers in intermediate risk individuals also favors the use of statins. For example, if the patient has high sensitivity C-reactive protein more than 2, or if they have a history of familial premature coronary artery disease, or if they have high lipoprotein little a, and when I say high, I'm referring to more than or equal to 50 milligrams per deciliter, or more than or equal to 100 nanomole per liter, or if their coronary artery calcium score is more than 0. All of these are situations where we need to start statin as a primary prevention. Now, for most low-risk individuals, that is their FRC, Framingham Risk Score, is less than 10, health behavior modification without pharmacotherapy is still recommended, with some exceptions. If we have low-risk individuals with low-density lipoprotein more than 5, or if their ApoB is more than or equal to 1.45, or non-HDL cholesterol is more than or equal to 5.8, who have statin indicated conditions, likely, for example, genetic dyslipidemia or familial hypercholesterolemia, or in individuals where their FRS is between 5 to 9, but their LDL cholesterol is more than or equal to 3.5, or their ApoB is more than or equal to 1.05 grams per deciliter, or their non-HDL cholesterol is more than or equal to 4.2, especially with other risk modifiers. Example, if they have a family history of premature coronary artery disease, or if their lipoprotein little a is more than 50, or their CAG score is more than 0. Why? Because the proportional benefit from statin therapy will be similar to that in other treatment groups. Treatment of this group would follow the intermediate risk approach. So even if they're in the low risk, but if they have these conditions that I spoke about, we treat them as intermediate risk group. Finally, evidence continues to show the benefits of maintaining low level of atherogenic lipoprotein throughout life at any age, at any level of risk, even among primary prevention individuals at low 10-year risk. The benefit of lipid lowering can be substantial, especially when the LDL cholesterol is more than 3.5. Thank you.
Thanks so much for your time today, Mohamed. You can find the Nurse Practitioner Podcast on Spotify and iTunes. Thanks for listening, and we'll see you for the next episode. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks for listening.